Good morning and welcome to all of you. I'm Anna. I'm therapy development specialist at FEops, and I'm very glad to welcome you in this education session organized by FEops at London Val 2021. The education objective of this session today will be mostly a case-based learning discussion to be as close as possible to your clinical interest, to your clinical reality. And we want to ensure interactivity with you. This is why we will propose you two polls. So we will ask you to answer to quick questions, and we will discuss on your feedback with the speakers. And there is also the possibility to ask questions for all the duration of the session using the chat. I will be checking the chat and I will share all the questions with the speaker. In this 30-minute session, will be focused on FEops HEARTguide as novel pre-operative planning tool for LAAo closure intervention, and in particular using Watchman FLX devices. Now it's my pleasure to introduce you our faculty, Dr. Panikker from University Hospital Coventry and Berkshire and Royal Brompton Hospital in UK. And he will share with you his experience in using FEops HEARTguide together with Watchman FLX devices. Now it's time to give the floor to our speaker. I wish you a good session and good morning, Dr. Panikker.
Thank you very much, Anna, and thank you to FEops for giving me the opportunity to present. I'd like to speak to you about a novel pre-operative planning tool that will hopefully improve your efficiency and success rates for implantation of appendage closure devices, in particular the Watchman FLX device. So I'll do this by taking you through two cases. So the first case I'll take you through their history is a 75-year-old male. He has a history of recurrent, persistent AF to which he is very symptomatic. He has hypertension. And the main contributing factor to why he needs appendage closure is that he has non-alcoholic liver cirrhosis. In fact, it was congenital passage, which his hepatologist believes, congenital passage of hepatitis B, that then led to his cirrhosis over his lifetime, which he then presented with in his 60s. He's diabetic, he has mild LV dysfunction on echo, and he also has thrombocytopenia. So two reasons for bleeding. With the cirrhosis, he has grade 2 esophageal varices, and he has a CHA2DS2-VASc score of 5, leading to a considerable stroke risk, and a Has-Bled score of 3, then lending itself to a higher bleeding risk. The second case is a younger 59-year-old male. He has initially paroxysmal AF, hypertension, mild to moderate coronary artery disease, and good LV function. He had a spontaneous subdural hemorrhage whilst on dabigatran, and this was managed conservatively, and of course his DOAC was then stopped. He then developed persistent AF from January 19, and unfortunately, as he was not anticoagulated, he had a right MCA territory, so medial cerebral artery territory infarct the following month. And then after discussion between the stroke team and the neurosurgical team, there was a decision to restart his anticoagulation, though accepting that he does have a high risk of recurrent subdural hemorrhage. His CHA2DS2-VASc score is 4 and Has-Bled is 3, so quite similar in their risk, but quite different risks. So the treatment objective in both cases was, of course, to minimize their thromboembolic risk, but by hopefully removing the need for long-term anticoagulation, then reducing their risk of recurrent intracerebral bleeding. So both patients had contrast CTs of their left atrium and left atrial appendage to help plan the case. So the FEops HEARTguide tool really did help in both cases, and I'll take you through why. So the workflow is that the CT is reconstructed in 3D, and particularly reconstructing the left atrium and left atrial appendage, including full measurements of the appendage around the ostium and the landing zone about 5 to 10 millimeters more distal to the true ostium, which is typically where you would implant the device. So there is also a 3D computer model of the Watchman FLX device, which is then overlaid onto the appendage, but not just overlaid. There is also, through mechanical behavior of the device and the tissue behavior, there is then a prediction made as to how the Watchman FLX will deform and then fit into the appendage. So every case will be different. So how does this fit into the workflow? Well, it's fairly simple. You simply upload the CT scan. So you just need the DICOM files, upload those to a secure server on FEops HEARTguide. This is obviously GDPR and data transfer compliant. And then within 24 hours or often less, there'll be a full analysis of the case in 3D to help you guide you for simple things like transeptal puncture, a relatively new addition, and then also simulated options of which device and which position would be optimal. And then on the day of your intervention, you can then review all of this and work out which position and size of device is optimal for your patient. So I'd like to move on to the first poll, just to get an idea of what your baseline thoughts are. So the first poll is, do you see a need to access a novel preoperative planning tool, such as FEops HEARTguide? And the answers are no, I'm fully satisfied with what I have. Perhaps I'm willing to discover new solutions to optimize my preoperative planning. And the last option, yes, I think it would be helpful. Actual solutions are incomplete at the present time for optimal heart team decision. So that's good to know. You know, to be honest, I think it'd be very difficult to say that standard preoperative tools are complete and sufficient. But I'd like to take you through really how this planning tool helped me. So the first case. The challenge in this particular case, as you'll see from this angiogram, is that it was quite a large appendage and it had multiple distal lobes, as you can see by this real-time appendage angiogram. And added to that, there was a complexity that both cases needed concomitant ablation within the left and right atria, or in this particular case in the left and right atrium. So that then led to differences in the way I would implant, because for being an EP physician, if I needed to go back in for a redo procedure, I would need to ensure that the device was not protruding too far into the left atrium. So how did the FEops HEARTguide tool help? Well, there were measurements made of the anatomical ostium, the landing zone, and also the appendage depth, as I'd alluded to earlier. And importantly, anatomical landmarks were created onto the 3D model. So that was the anatomical ostium, which you'll see in blue, the landing zone, which you'll see in green here, the fossa ovalis, which is a relatively new feature, but certainly identifies it, and that's in yellow here. The mitral annulus, the circumflex artery, and then the fluoroscopic projection is also shown here as you move the model. So I'll just show you through that in video. So we're going to zoom in here. Moving the model, you can see how it changes in the fluoroscopic projection. Here's the anatomical ostium measurements. And you'll see here, we can also take on and off certain measurements, so certain features such as the mitral annulus, show the circumflex artery, so you can see how close it is to where you'll be implanting the device. And then moving on, this is a relatively newer feature, which I've found quite helpful. So when the fossa ovalis is defined and the body of the appendage is known, we can see the main axis for the body of the appendage and then the best fit lines for where transeptal axis should be. So as you can see on here, we can look at which one is most coaxial. We can delete the two that are obviously not coaxial. And then looking at this on face, we can see that that line is not coaxial. So interestingly, in this case, the typical position, which would be inferior and posterior, is actually recommended to be coaxial with the main body of the appendage, to be inferior and anterior. So that gives you some interesting information. And in this particular case, you get an area-based diameter, a perimeter-based diameter, and then an actual drawn diameter. So the maximum diameter was 28 millimeters, minimum was 23. So we knew that a 27 would be insufficient. So it was either 31 millimeter or 35 millimeter device that FEops then automatically modeled to see which would be the best or optimal fit. So 3 options were given in two. So 2 positions were provided for the smaller size and 1 for the larger size, which was more in a distal position. A proximal position. And then based on the comparison between the simulated cross-sectional diameter and the nominal size, a compression was able to be given so that we could see how much compression, what percentage compression we would achieve. And it's obvious to see here that the distal position of the smaller device would give the best compression. So showing how this would look. What you can see here is that this is the proximal position of the smaller device, a distal position of the smaller device, and then a proximal position of the larger device. This, unfortunately, if it was positioned more distally, would lead to overcompression and distortion of the frame. So a typical overlay would be seen in the blue, as you can see here, but the novel feature of the FEops HEARTguide is that it allows you to see how the frame would deform into the shape of the appendage, and that's very, very useful. There are a color bar gives you an idea of how much gap there is between the tissue and the frame. So of course there will be a gap on the front face because it's facing the left atrial body, but then what you want to see is that there are no gaps around the perimeter. So when you spin the model around, you can see if there are any significant gaps. And as you'll see here, this is that patient. So we managed to deploy the device in a nice looking position. And as you can see here, it does protrude slightly, but this is the optimal position. If we pushed it further in with the 31 millimeter device, it then led to overcompression and distortion of the frame. And as you can see here in an X-plane or biplane view at 0 and 90 degrees, there were no gaps around the device, which was appropriately adjusted to the Nyquist limit on color flow. And then injection of contrast after deployment of the device showed it was very well seated at the ostium. So this is just, I guess, the proof of pudding that the Watchman device, this is how it was modeled in a distal position. But then how did it actually look once we did a CT scan? Because on fluoroscopy, it's very difficult to match the views. So on the follow-up CT scan, and that was particularly performed in this case because of the presence of esophageal varices, we didn't want to keep instrumenting the esophagus with a TOE probe. So in this case, you can see the post-procedure appendage closure device is actually in an extremely similar position as the modeled predicted position. And of course, in this case, there is no flow behind the closure device, and that's why the distal appendage does not show up. And as you can see here from the simulation compared to post-op, there's very little, 1.2 maximum 1.2 millimeter difference between the devices in terms of their position and size. So that's very reassuring. So the simulation predicted the size and relative proximal position within the appendage. It demonstrated sufficient compression of the device, and the post-op CT, as we've seen, demonstrated a very similar predicted frame shape and position. And in this particular case, I chose the smallest device size to achieve acceptable compression and a distal position, taking into account the fact that I'll be performing an AF ablation on the same sitting, and he may need a redo procedure. So the second case, this is it was a more challenging anatomy. So as you can see here from the angiogram, there's a wide ostium, a relatively short running, and a very marked retro pulmonary artery angulation of the distal lobe, what we'd call a retroflex chicken wing or reverse chicken wing. And this case also required a concomitant AF ablation. As you can see, that's modeled nicely on this 3D reconstruction. So in this particular case, you can see that there are 3 positions modeled for the 27 millimeter Watchman flex, and the 31 millimeter device had a single position modeled. In my view, this position here would be the best position, as it was not interacting too much with the distal portion of the appendage. Now, of course, the flex is a much more rounded off device, so that actually you can have it near the distal tissue, but I would still prefer some separation between that. So this is a TE, and this is the pre-deployment angiogram of what the device looks like. And as you can see, it's well seated at the ostium here. And moving on after deployment and then angiography, we can see that the device sits in a very nice position. And that's confirmed again by the contrast injection. So again, the 3D simulation really helped by telling me which device would be optimal, and I could see the positions that would be there, and I chose the middle distal position, and it demonstrated that it would be sufficiently compressed in this position without excess device protrusion, which again was very important for the procedure that he was about to have and then went on to have afterwards. So based on this information, I'd like to do a second poll. So if we could start that now. So the second poll is, after these case reports, how do you perceive the benefits of using a tool such as FEops HEARTguide into your practice? Do you think that there'd be no additional benefits? Do you think there'll be some benefits to increase the confidence in decision for sizing and positioning? Or do you think that this software has real innovation in preoperative planning to help predict potential complications? So please vote now. Okay, so I can see there's a small shift towards understanding, hopefully, the benefits of this tool. And I fully understand it's not for everybody, but I hope you can see that through use of preoperative planning, you can certainly improve your efficiency. You really know, and you can really predict where you will be implanting. And that's me without, of course, I had to start with trialing this. And every case I've done so far has been very, very close to where the predicted position would be, and frame deformation also was very similar. So I think the predictive value is extremely important, and it also then improves your efficiency on the day, improves your success rate, and minimizes the number of devices that you would have to try. So in conclusion, appendage closure interventions can be challenging, and that's because the appendage varies markedly in its anatomy and how it behaves with the device. So even calcification can be there. The lobes won't always expand in the same way that you think they will. And preoperative planning, incorporating 3D simulation, I think can really help improve our efficiency and help you select which device and which position would be optimal. And it certainly, for me, helps to reduce my procedure times and potential costs, as since using FEops, I've only really had to use one device size. I may have to reposition it slightly to achieve the optimal position, but only one device size. So that will reduce costs to both you and the patient, and therefore improve your procedural success rate. Thank you very much. I invite any questions.
Thank you for the clear explanation. And we have some questions in the chat. One is about the anatomical measurements. The question is anatomical measurement complete in comparison with the classical preoperative planning tool?
Yes. So in my opinion, yes, absolutely. So if you have ever asked your radiologist to do a CT reconstruction for you, they will usually have perimeter-based and area-based anatomical measuring tools. So essentially, they will trace around a best fit line around the ostium, around the true ostium, which isn't usually where you deploy, and then the landing zone, which is often defined by where the circumflex artery is. And at that point is where you would optimally deploy your device. So you should have two measurements in those areas, and FEops adds the extra line-based or direct-based measurement of minimum and maximum measurements as well. So you do get the full gamut of measurements, and in addition, of course, depth. Okay, thanks. Another question is about the transeptal puncture. So the question is the model based on the transeptal puncture axis you pick or is not taken into consideration? So I think is the simulation
are linked to the selection of the direction that you do or not? I could help you in case you want some technical support.
I think so, if you could.
Yeah, I can answer on this. And I will answer that no, it's not linked, because the transeptal puncture evaluation is something that is a sort of previous phase. It's just an anatomical analysis of the problem, so of the patient. Simulation are not linked to the selection that you do, but usually we perform simulation applying the FEO. This is why we are trying to position the device as is suggested by the FEO, and the transectal puncture analysis is mostly focused on identifying the direction that is as most coaxial as possible with the LAAo direction. So this is not a direct consequence, the simulation related to the selection of the direction, but we are following, we can say, the same instruction about the use of the device.
Yeah. So I think they do end up being quite similar, because the modeled position of the device that you deploy will be based on the axis of the main body of the appendage. But of course, then the tissue characteristics and any pectinate muscles or such like will then be taken into consideration. And then naturally, the best fit for that will be the transeptal position that are modeled. But yes, the transeptal position doesn't directly influence the model. So Anna.
Yeah, the other question is, does the computational model take into consideration tissue characteristics and pectinate position? Does it show where anchors are relative contact of anchors inside the appendage? So the first one is about the characteristic of the tissue, and the other one is about the anchors.
So this model, and Anna will obviously elaborate more on this. The more information the model has, the better it gets. It's AI learning, and so tissue characteristics are definitely taken into consideration, and then of course the pectinate muscles, of course, will be taken into consideration. I think one of the other questions in the chat, part of that was, does it show where the anchors are and where their relative contact are within the appendage? And I believe it doesn't. Is that correct, Anna?
Yeah, it's correct. Yeah, because we are indicating the model, but we are not focusing on the anchors. Yes, it's correct.
Yeah.
Okay, yes, thank you. We don't have any additional questions. So in conclusion, I would like to thank you for your very clear explanation and also to answer to all these questions. And I would like also to thank the audience for participating in this session, also so actively. And thanks again. And I wish you a good PC London Valve 2021. Thank you.
Thank you.